Good afternoon, ladies and gentlemen. Our webinar is beginning. Welcome. My name is Steve Love, President and CEO, Dallas-Fort Worth Hospital Council. We really appreciate you being here today. We're going to have an educational webinar hosted in coordination with Forvis Mazars, an associate member of the Hospital Council. In fact, they're also a year-round sponsor of the DFW Hospital Council. Today is a very, very important topic dealing with navigating 340B, especially some of the key updates and some of the recommended strategies. As you know, for more than 30 years, the 340B pricing program has provided financial help to hospitals that serve very vulnerable communities and helps manage the rising prescription cost. Section 340B of the Public Service Health Act requires pharmaceutical manufacturers participating in Medicaid to sell outpatient drugs at discounted prices to healthcare organizations. Today, we're going to speak with two national experts on the recent updates, recommended strategies. Our speakers today are Brian Bell, who's a principal, and also Travis Belson, who's a doctor of pharmacy and is a manager also at Forvis Mazars. They have worked with Forvis Mazars for many years, are valued friends of the Hospital Council, and I think you're going to be in for a really good educational session today. Now, before we begin, I do have one administrative note. If you have any questions, please type them either in the question box or in the chat box. At the end of the presentation, we'll look at the questions and our experts will answer those. And so with that, ladies and gentlemen, it's my pleasure to introduce to you Brian Bell.
Thank you so much and appreciate the introduction and excited to be here with you all today to kind of navigate and think through the 340B program and its current status and all the changes that are occurring. We know that every day that we hear different updates either from the federal government or manufacturers, and Travis and I are going to spend some time and really help you think through some strategies as far as maximizing your program and potentially just maintaining your program. So from a kind of an agenda or learning objectives, Travis is going to spend a fair amount of time on the history, purpose, and key components of the program. We're going to dive into internal auditing and controls over your program, and then start to explore methods for analyzing and hopefully expanding the profitability of your 340B program, and then look at some tools and resources available for tracking and maximizing 340B savings, as well as understanding and diving into the contract pharmacy networks, entity-owned pharmacies, and then really wrap up with a current landscape. There's a lot of court cases going on right now. There's a number of state laws, federal laws that are coming into play across the country. So wanted to spend a little bit of time on those items and then wrap up with some potential future direction of the program around advocacy and other items. Just want to spend a minute on Forvis Mazars. So many of you on the phone may know of BKD, DHG, Forvis. So when BKD and DHG came together, we became Forvis. And then as of 6/1, within the U.S., we have merged together with Mazars and have become Forvis Mazars in the U.S. And really it has expanded our footprint as well as kind of our focus. So not only do we have relationships with all of our strong hospital and healthcare clients, now we also have a payer group. When we think about how we approach our clients and really how we try to help our clients work well in the healthcare landscape, we've developed a continuum of care. And you can see as you look at acute care, post-acute care, and community care, These are all of the different providers across the country that we're working with. And really, our goal is to help them on three fronts. So one, from an audit perspective, a tax perspective, and then where Travis and I sit on the consulting side. And really, from a consulting perspective, our goal is to help our clients maintain compliance and ultimately maximize their revenue, their margins, and their savings. A little bit deeper dive where we focus on the consulting side. We have really four legs of what we call healthcare consulting. Strategy and finance, really focusing in on strategic partnerships, acquisitions, value-based reimbursement, and really modeling out what those things look like. Healthcare reimbursement, so all things Medicare cost report, and not just preparing the cost report, but really focusing in on the strategic opportunities around the cost report. Performance improvement. So Travis and I within the pharmacy and 340B team sit within performance improvement, but we also focus in on revenue cycle, cost management, as well as physician services. And then with the addition of Mazars to our team, really excited to also focus in on the payer side. And what we have found early on in our new relationship is our payer services, while they're focused on the payer side, there's a lot of benefit there that we can move over and help our traditional healthcare clients. So wanted to share that. I know our name's changed a few times, so I always like to point some of those things out. But with that, I want to hand it over to Travis, and he's going to take a deep dive into what is 340B, how did we get to where we are today, as well as some opportunities. So with that, Travis, handing it over to you.
Thank you, Brian. So I think it's helpful for us to even think back to the start of the 340B program, really designed to provide some front-end discounts on drugs. And it's important to keep in mind, really, what is the goal of the program? How are those discounts applied? And so manufacturers are required to apply a discount to covered entities and by doing so, gain access to those Medicaid and Medicare programs. The 340B program, is really intended to support organizations in treating those underserved communities. And the idea by providing those discounts, which can average, anywhere from 25 to 50%, that covered entities can really provide more services to more patients. And there's a lot of latitude in how they go about doing that. Now, the program's changed a fair amount under three presidents. And, there were some notable changes back in 2010, which in many ways have led us to the current situation that we're hearing so much about in the headlines. So, the addition of some additional covered entity types, and then also the expansion of contract pharmacies. But I want to spend a moment and think about some of the eligibility for participating within the 340B program. Really limited here to our nonprofit healthcare organizations that have either a federal designation or receive federal funding. And we can, simplify this really into thinking about our hospitals and our grantees. And then further, we can segment those hospitals into two categories. So your GPO prohibition hospitals or your rural hospitals, and each has some unique characteristics to their covered entity type. But want to take a moment to really focus in on some of the participation requirements for those hospitals. And so with the exception of those critical access hospitals, they have a particular DIS percentage required to participate. So that becomes really the main criteria for maintaining eligibility in your program. And so really important here for organizations to be monitoring that DIS percentage. And we recommend organizations are working to continuously track that DIS percentage throughout the year and looking to monitor whether or not they're going to make that threshold. And so one strategy we see some of our clients employ is creating a dashboard that really tracks that this percentage or eligible Medicaid days throughout the year to make sure that organizations are keeping that top of mind, and then also able to address any type of eligibility concerns promptly. I know we work with a number of clients on their strategies to be able to meet their DISH requirements, and always looking for different ways to be able to quantify all the eligible Medicaid days possible. But sometimes you're not able to meet those requirements and may need to navigate between different covered entity types, and it's not always seamless. So really important here that organizations are continuously tracking that DISH percentage and then understand some of the implications behind that percentage. A major part of the 340B program is going to be audits, whether that's for covered entities or manufacturers. And if we're looking at audits of covered entities by HRSA, we have 152 audits posted, still have 48 outstanding. And it'll be interesting to see why they are being held. Typically in the past, we've seen these audit results released as large batches. But there has been some concerns that this year HRSA may be seeing an increase in findings that are contributing to a delay. But overall, what we've seen thus far is audits spanning all covered entity types. And when we're looking at those audit results, there's a fair amount of manufacturer paybacks. We frequently receive questions from our clients, mainly in two areas right now. So one around referrals, and then two around some of these direct replenishment models or alternative distribution models. In terms of referrals, mainly centered around some of that expansion of the patient definition, stemming from post-Genesis case. Right now, it's a little bit too early for us to tell what type of direction HRSA is going to take in expanding any type of patient definitions. So really, at this point, recommend our clients continuing to follow that 1996 patient definition guidance, coming back to your policies and procedures and really understanding how do you define a patient for your program. On the alternative distribution side of things, we haven't heard of any audit findings related to these type of models. Something we're monitoring, but I don't think necessarily the risk is associated with 340B compliance, so long as you have the right tracking mechanisms in place. I think more of the risk is around how you meet some of those state and federal requirements. So on the manufacturer side of audits, recently Eli Lilly had received HRSA approval to audit for duplicate discounts, specifically for the managed Medicaid programs. And this is significant because it's the first time HRSA has provided approval for looking at managed Medicaid duplicate discounts. Historically, HRSA is only focused in on fee-for-service. And notably right now, 2 hospitals have even recently sued HRSA to block some unlawfully authorized audits by Johnson & Johnson. But I think it's important to keep in mind here that, under that administrative dispute resolution process, which took effect this past June, manufacturers are required to audit covered entities prior to filing a formal complaint under that process. So I think it's something that's really important to monitor and has some big implications for the program. But I think the takeaway here for organizations is really, if you receive requests by a manufacturer or a third party operating on behalf of the manufacturer, it's important to be able to respond to those requests and operate in good faith to prevent those from opening up to any further auditing. So, the 340B program, it's complex. There's a lot of components that go into maintaining compliance, and we work with organizations really to help them build out some strong compliant foundations that really gives us the confidence and the right framework to be able to maximize any potential 340B strategy for a given organization. Right now we're experiencing significant legislative activity, and there's going to be a lot of changes coming up in the next year with some major implications. So it's really important here. Organizations are prepared for those changes and setting up their programs in such a way that's going to position them to navigate those coming changes. And that really starts with compliance. And, the hallmark of some of the high performing programs that we work with is having a strong oversight committee that takes a compliance first approach. And really works to manage the 340B program across the entire organization. And the strength of any of these type of committees is really that ability to bring together a diverse group of stakeholders. And so that means incorporating departments like IT, legal, patient financial services, reimbursement, and others. So again, really just want to emphasize here that a strong compliant foundation really paves the way to optimizing any program. But before we even begin to think about optimizing any type of program, we need to be thinking about what are those inroads to the 340B program. And I think this is a crucial step to be able to maximize the scale of any given program. So we need to be asking ourselves, what are those freestanding clinics that are sitting below the line on your cost report? And we need to be assessing, does it make sense to meet those accreditation standards, to become provider-based clinics and then register for the 340B program? And so what that ultimately means is we need to be assessing what's the pickup in reimbursement when we break out that professional and technical component for our Medicare patients. What's the savings associated with those clinic administered drugs? How is that going to impact our rebate performance? And then, what's the expected savings around our contract pharmacies or our entity-owned pharmacies? So this can be a significant process to move over to a provider-based status, but generally what we've seen when helping organizations implement these plans, it's often well worth pursuing for both that Medicare change in reimbursement and then also to capture the 340B benefit. And so I want to shift our focus now to how do we manage our 340B program and really capitalize on driving some savings. And it's going to be important that we're looking at some key performance indicators, and it comes down to tracking dollars, tracking rates, and tracking some quality measures. And I think if there was any one metric to really focus in on for the group, it's going to be looking at that capture rate. And so we can think about it as, how many prescriptions are you capturing for your program that are generated by your providers? Said differently, it's really thinking about your maximum 340B opportunity. And so we typically look at the capture rate in two main ways. So one, identifying some contracting opportunities, and then two, monitoring the performance of your in-house pharmacies. So closely monitoring that capture rate is going to tell you where those prescriptions are going. Is it going to your in-house pharmacy? Is it going to your contract pharmacies? Or maybe it's going to some non-contracted pharmacies. And within those non-contracted pharmacies, there may be some opportunity to set up a contract, depending on the composition and the volume of those claims. For the in-house pharmacy, that capture rate starts to give you an indication of how well your pharmacy is performing from a 340B perspective and what potential you should be realizing. Generally, the industry accepted standard for capture rate is around 60%. And I think it's also important organizations are not only looking at their overall capture rate, but then also breaking it out into non-specialty and specialty. And really on that specialty pharmacy side, organizations really need to be internalizing majority of those prescriptions outside of any payer restrictions. But, lastly, I like to look at the capture rate through the lens of a pharmacist. And I think it's an important perspective for leaders to have as well. Your capture rate for your in-house pharmacy is really a direct reflection of the relationship your pharmacy has with your providers and your clinics. And so when we work with organizations on their outpatient pharmacy or retail or specialty pharmacy strategies, we often begin with that capture rate. And that really helps start to guide where those potential pain points may lie that are really limiting prescriptions being filled through your pharmacy. So major takeaway here is going to be we need to be closely monitoring our capture rate, because in today's environment with all the contract pharmacy restrictions, this is going to be the best way to maximize 340B savings. Another key metric leaders need to be aware of or attuned to is going to be 340B savings. And this is going to be important on several fronts, but I think the main takeaway here is going to be, organizations need to know how to properly assess their savings. And, when we start to look out across the healthcare industry, we're seeing increasing calls for transparency. Whether it's the Pricing Transparency Act or PBM reform, or specifically in some of the proposed legislation for the 340B program, there's going to be a need to showcase, how your savings are being calculated as well as how they're being used. So CFOs really need to know how to calculate this. And oftentimes we see organizations not including all of the costs that go into maintaining a program. So that means including some of the vendor fees or external consultant fees, as well as the overall savings. And, further, I think CFOs also need to have line of sight into how those savings are being used. And I think this can become an incredible tool to be able to engage with policy decision makers and start to advocate for the 340B program. There's so much change looming out there for the program. It's really important here. Covered entities are speaking up and showcasing how the program impacts their communities. Oftentimes without the 340B program, these organizations wouldn't exist, and there's some larger implications for those communities that we serve. Because of the manufacturer restrictions, in-house pharmacies are becoming more attractive. Keep in mind that those manufacturer restrictions are really enforced at the wholesaler level for those contract pharmacies. And so I think we can summarize the entity-owned pharmacy benefit in maybe two different ways. One from a financial perspective, and then two from a patient care perspective. Financially, we're going to be able to get shelter from those manufacturer restrictions. It's going to also provide some better margins when compared to our contract pharmacies, where we have administrative fees and dispensing fees, which we continue to see increase year over year. But I think more importantly, and when done right, these entity-owned pharmacies can really provide a much better patient care experience and drive some positive outcomes. It opens the door to some additional ways to extend access to patients or provide some additional revenue streams like specialty pharmacy, transitions of care, mail order, and especially around administering your prescription benefits for your employer plan. So ultimately, these pharmacies make it easier for covered entities and patients to be able to access 340B pricing. Lately, there's been a lot of interest in leveraging a pharmacist to help qualify prescriptions for the 340B program. I think this is a great opportunity for organizations to have a positive impact on patient care and expand the role of ambulatory pharmacists in maximizing your 340B opportunities. I think call out a couple points here when establishing these models. It's important that we need to show the pharmacist is embedded in an eligible location. So that means having some Medicare charges. And part of the challenge right now is that Medicare does not recognize pharmacists as providers. And so with that being said, we can't have standalone pharmacy clinics. Two, I would say, want to make sure that, you have clarity in how are you meeting the patient definition. And then lastly, being consistent in not only your processes, but how you're billing across all of those payer types. Something that is often overlooked by organizations is how do they manage vendors, and especially within the 340B program. I can't tell you how many times we've seen organizations that outsource some of their revenue cycle or maybe their EMR functions that just don't fully understand how data is flowing into their 340B software. And so I think some, pertinent questions to get you starting to think about, some of that is, what are the qualification settings? What's hitting my accumulator? Are we being too restrictive? What is my WAC spend? How much of that is good WAC? And, often we go through this process of reviewing data feeds and working with organizations on looking at their split billing software. I mean, just the other week, we had a client with some really high WAC spend, and we began to drill down on some of the data feed and looking at it to see by department what that WAC spend was, and notice for our surgical units, we weren't seeing any waste come through. And, we would expect to see, waste or those waste modifiers flowing through there and being able to accumulate on that. So, another thing organizations can be even looking at is actively monitoring those 340B accumulations. So if you're continuing to see accumulations rise without corresponding purchases, you may have a capture issue, which can potentially have some significant revenue implications, but can also be a concerning 340B compliance risk. So really important that organizations actively monitoring what's hitting their accumulators and comparing that to utilization to make sure that they're capturing all those medications. So it's hard to believe that the manufacturer restrictions have been around for almost 4 years now. Began with a handful just to see how they could limit the 340B program. And, when you think about it, they've been pretty successful in limiting it so far. And this is still playing out in various settings with the courts and states, but ultimately think it's going to come down to Congress. And as a result of all these restrictions, it's placed a lot of hospitals at risk for closing that really rely on 340B savings to sustain their operations. And so I know this figure is a few years old, and there's just not a lot of publicly available great data on this. But what we're seeing in many cases with our clients that these restrictions are now upwards of 70% of their savings, and it's causing organizations to have to make some really tough decisions. And that begs the question: it's what options do covered entities have? There's a company by the name of 340B ESP that's contracted on behalf of the manufacturers. Really its purpose is for two things. Covered entities may elect a single pharmacy or can submit claims data in exchange for access to pricing. But there's some notable issues with the system, and covered entities are often concerned about how the data they're going to submit is going to be used. And it's important to keep in mind that the duplicate discount is not always, the same based on your perspective as a manufacturer versus a covered entity. Covered entities are mainly concerned about duplicate discounts with the Medicaid program, but manufacturers are looking at duplicate discounts where they have to pay a discount on both the 340B program and Medicaid, and then also for PBMs on potentially the same claim. So ESP is one option, has its own issues, and truthfully, it's not an overly effective way to counter these manufacturer restrictions. It may only move the needle a few percentage points. So others are, looking to partner with their prescribers to potentially look at changing prescribing habits to non-impacted NDCs. Others are looking to expand their contract pharmacy network. So that means coming back to that capture rate. But I think a recent program development that is exciting and we're starting to see more and more of is these direct replenishment models or alternative distribution models, where you're effectively having products shipped directly to the covered entity to be able to bypass those bill to ship to accounts for those contract pharmacies. This idea was originally introduced at one of the 340B coalitions a few years ago, but starting to see it more and more. And from some of the clients that we've worked with in implementing these type of models, we've seen them have a fair amount of success. In some cases, upwards of 90% of savings were covered, but a lot of that is heavily dependent on the composition of your contract pharmacy network and where those prescriptions are going from a geographical standpoint, and also the type of prescriptions that are flowing out. So really important for organizations that are considering looking at implementing one of these type of models to understand, what are the prescriptions that are being carved out of our program, where are they being filled, and then starting to think through the feasibility of an arrangement like this. I'd say the biggest hurdle here in getting one of these models up and running seems to be, setting up a wholesaler's or a distributor license, but, really varies by state to state in which you operate in. Ultimately, the best way to address these manufacturer restrictions is going to be at entity-owned pharmacy. Really partnering with your prescribers and others in your organizations to say, how can we really internalize all the prescriptions that are coming out of our organization? Right, Brian, I'll turn it over to you to walk through some of the program updates here.
Yeah, absolutely. Thanks, Travis. And we're going to turn the page a little bit and really try to get out ahead of, what's going to occur in the future and what has occurred, in the near past. So, Travis, if you can move on to the next slide. So I'm going to spend a little bit of time on the OPPS remedy. This, for the most part, is history. Everyone that took those cuts by applying those modifiers from 18 through late 2022, you should have received that lump sum amount. And really, when we think about this was a big deal, and really where a lot of organizations are focusing their time now are on their Medicare Advantage plans. So, Travis, if you can move on to the next slide. What our recommendation is to really start to, one, you should have assessed the lump sum for your Medicare traditional. What we found as we assessed many of those lump sums is that they were kind of right in line with the claims data that stood behind them. For the Medicare Advantage, it's still important to assess these lump sums. We still have clients that are going through that process to say, what should the Medicare Advantage plans have paid us? And it's a pretty significant amount for most organizations. And right now, when we think about the Medicare Advantage plans, they weren't kind of touched on in the final rule. So it has left many organizations in a situation where if you see the headlines, many organizations are terminating some of their Medicare Advantage plans because of the assessment amount, as well as kind of the denials and other barriers with the Medicare Advantage plans, with hopes that they'll get a higher rate. Revenue recognition, the revenue should have been recognized in the year that it was received from a financial perspective. And then for budgeting, you should budget for that ASP plus 6% for your separately payable 340B drugs. Because this was budget neutral, there's a 0.5% reduction for other services. So what we're typically seeing that this means is it's about a 20% reduction of that lump sum that you received. The good news is it's spread out over a number of years. So that 0.5% reduction shouldn't be very impactful. And then the other thing to note is that 0.5% in reduction is spread out over all 340B as well as non-340B organizations. The Genesis versus the government case has received a significant amount of attention, and I don't think a week goes by where we don't receive a question as far as what does it mean now that the courts have ruled in favor of a covered entity for patient definition. So kind of the background on this case, back in 2017, HRSA conducted an audit at Genesis Healthcare. Genesis Healthcare is a community health center. It participates in 340B and in South Carolina. And ultimately what happened is Genesis didn't agree with the patient definition findings. So they fought it in courts, and ultimately the ruling was that they overturned, and ultimately the way Genesis was interpreting the patient definition was allowed based on the court ruling. Now, what does this mean for other covered entities around the country? Probably not as much as we would hope that it would. Unfortunately, this was for one community health center in South Carolina, and ultimately they spent a significant amount of time and money fighting this case. So I think it does set the precedence for future cases if organizations would like to challenge patient definition. I think more importantly, what the Genesis case does is, as we think about future regulation, I think the Genesis case really puts it on the front burner for Congress to act on patient definition and really provide a clear patient definition, both for our mixed use drugs, which I would say is pretty clear, but also on the contract pharmacy side, and also take a step further and really build out what is a referral and what is not a referral. So this case, I think, will force Congress to act on that in future legislation. I'm going to spend some time talking about future legislation, but this case is going to be very, very important as new legislations build out, especially around patient definition, which is kind of the means that the manufacturers have used over the years, because they've really been able to challenge patient definition as well, which is why they've been able to put restrictions in place that most likely are unlawful, but unfortunately the law is not clear. Unregistered child sites. So during the pandemic, we were able to basically, as soon as a clinic met provider-based requirements and would be reported on a reimbursable line on the next cost report, they're allowed to participate in 340B. Unfortunately, there was a lot of kind of misunderstanding as far as, was this related to the public health emergency or was it not? And ultimately HRSA originally said, nope, this is not related to the public health emergency. Therefore, it's going to move forward over the course of the future. Well, when the public health emergency ended, HRSA changed their tune on this and ultimately said, no, in order to be eligible for 340B, has to be on an eligible reimbursable line of the most recently filed cost report and registered. So during the pandemic and during the public health emergency, no wait. And now we're back to that almost 18 to 20 month wait to get a clinic up and running. There is currently a lawsuit that there haven't been a lot of updates, but more than 40 hospitals went together and said, no, HRSA, you told us that this was not related to the public health emergency, and they're going to fight it. There's a lot of documentation that kind of goes against the stance that HRSA is taking today. We're monitoring this. I've spoke with individuals that are involved with the lawsuit, and there's actually some thought that we could get a ruling without any true court date. So we're monitoring this closely because this is a really big deal for organizations that have clinics that are not eligible today. And when they become eligible, they immediately become eligible for 340B. So with that, wanted to spend just a few minutes on what does it look like to take a clinic from not being eligible for 340B down on a non-reimbursable line, typically on line 192 of the cost report, and move it up to a line to line 90 where it is eligible for 340B. The provider-based timeline, it can take a lot of time just to convert the clinic. And oftentimes we see these conversions take 6 to 9 months. But from a reimbursement perspective, we see a reimbursement increase as well as being eligible for 340B savings. So really what that timeline looks like is typically start out with assessing what is the financial impact for reimbursement as well as 340B, identify gaps from an accreditation and licensure perspective, as well as the other provider-based requirements around integration, and then ultimately starting that provider-based conversion. And oftentimes as we start, we know that some of the clinics may never be able to meet all those requirements. So we automatically rule those out. But for all of those clinics that we know can meet the provider-based requirements, whether it's around licensure, accreditation, and other areas, we start that conversion. And then the goal would be by the time we file, or at least by the time we reach our year end, we have Medicare charges and expenses on a reimbursable line of the cost report. Therefore, when we file that cost report, we can include it on line 90, and then we register those clinics. And then the following quarter, so for example, if we register during the October registration cycle, those clinics would be eligible to participate in 340B on January 1st. There's a lot of functional teams involved in these operational changes as we move clinics over to hospital-based. And it's really key for all of those groups to work together in order to have an effective, efficient conversion. The Inflation Reduction Act, also a lot of talk around this. 340B Health has put a calculator out there to say, what does this impact look like? And when we think about the Inflation Reduction Act, this was the government's way of saying, as a payer, we should be able to negotiate the cost of the drugs. And with that, and as this has been pushed forward, starting in 2026, the federal government will negotiate cost for drugs, and they pick 10 drugs the first year. And really, what does this mean? And so what does the rebate structure look like? What does this mean for 340B? And then what does this mean for the reimbursement we're going to get? So as the cost goes down and those negotiations occur, most likely our reimbursement is going to go down as well. So there's a lot of talk around what does this mean as far as reducing our 340B savings? What does it mean around reducing our reimbursement? And then on the positive side, or at least the goal behind this, is to help patients avoid high out-of-pockets and start to really focus in on reducing that cost. I think there's a lot of debate today around, is this the right approach? Is it going to hurt more than it helps? So as we get into this, I think it's really important to use some of the calculators that have been built, work with your consultants to think through, what does this mean going forward, both from a cost and reimbursement perspective? And then another side, just kind of on what does it look like, and probably got ahead of myself in my comments, but it does remove the rebate cap, and the goal is to slow the rate of price increases. And there are some inflation parameters built out within the Inflation Reduction Act that I really think will help, because we'll be gone from the days where the manufacturers are, if they sell and are bought by another company, all of a sudden we see this big rate increase. So there are some good parameters in here, but we don't quite know what it means, or at least need to calculate what it means between what's the difference with the 340B price, what's for our contract pharmacies, and then what drugs are going to be selected as we move forward. So many of the drugs that were selected, Eliquis, there were a number of diabetes drugs. What will that selection process look like? And then what happens when they start to get into, today, we're only on Part D drugs, but what happens as we get into some of those separately payable Part B drugs? And then the modifiers for covered entities. So as part of the Inflation Reduction Act, historically, we've been required to apply modifiers for 340B drugs for our separately payable 340B drugs in order to reduce the reimbursement. Now, CMS is asking all covered entities to apply a TB modifier to their 340B drugs so that they can use this from an informational perspective and potentially exclude them from some of the Part B inflation rebates in the future. So these modifiers are informational today and going forward, but we expect for CMS to not only use it for the Inflation Reduction Act, but they'll also be able to really have a good idea of, how they're paying for those 340B drugs. So important to note that we need to have these modifiers on those separately payable claim lines, and that we've rolled that out for all of our covered entities. And then the ADR. So Travis talked about this a little bit. The ADR was created or at least required under the Affordable Care Act. And, it took a number of years for the proposed ADR process to even be implemented and pushed out. As it was pushed out, this was and organizations really started using it because of the manufacturer restrictions. The courts ruled that in favor of the manufacturers that the current ADR process was not allowed to be used. So what happened is they went back to the discussions, rebuilt the ADR, and really started to say, here's what we're going to use when a covered entity has a dispute with the manufacturers. Before we jump into the ADR process, there are requirements around how we have to discuss those with manufacturers, make sure that we've done our due diligence, and before we submitting all these claims. There's also a lot of talk around the impacts of the Chevron case, and what does this mean as organizations use regulations and the proponents of that start to use the Chevron case ruling to challenge that, and probably in a very effective way. So there's a number of law articles out there about how the Chevron case is going to impact healthcare and many of the regulations. So something that we're closely monitoring, especially when it comes to 340B and where we think the ADR will really be impacted. And then the manufacturer restrictions. So when the manufacturer's restrictions started, I was the first one to say that I truly thought that these would be settled in court. I have been pleasantly surprised that as these restrictions have, continued to expand, continued to significantly hurt covered entities around the country, that the states have really picked up the battle. So very similar to what we see with PBMs and trying to regulate the PBM, many states, as you can see by this map, have stepped up and really challenging the manufacturers. And what has happened is the manufacturers are following the state laws. So Arkansas was the first one, and then Louisiana, but Arkansas really has set the tone for how these state regulations that prohibit the manufacturers from putting restrictions in place should be written. And the biggest piece of that is because of the enforcement. So you can look at this map and see where the bills have been passed. In the states that have passed law has been very, very effective. Typically about a third of the manufacturers are following state laws. For those that are not, those manufacturers are starting to be fined. In the yellow states or the orange states, those are states where the bills have been introduced. Oregon and Utah have failed, and those did not get out of either chamber. And then in Kentucky and Rhode Island, those are through one legislative chamber, but still have not passed. And then there's a number of states. So like, for example, in Ohio is very, very close to getting theirs passed. And a lot of these expect to be passed in the next legislative session. And then at the federal level, we almost need a bigger slide in order to kind of list out all of the different acts that we think are going to impact pharmacy and 340B. And I won't read down through all of those, but there's many different approaches to how Congress thinks that 340B should be regulated. When we look at these bills, some are bipartisan, some are not. And so when we think about the three major bills that we're seeing, the 340B Access Act, it was sponsored by Representative Bouchon. This is in accordance with the National Association of Community Health Centers. And what has happened is NAC has kind of joined forces along with about 19 other partners, including the manufacturers, to push this act forward. And ultimately, it would be very, very devastating for a lot of hospitals, and the restrictions that are being put forward, as well as patient definition, as well as kind of how do you qualify. So this is very targeted on hospitals. The Patients Act, sponsored by Representative Masui out of California, the goal of this act is truly to restrict the contract pharmacy. So when we think about all of those state laws that we previously looked at, this would be the federal law that would make those state laws basically across the board. And that's the sole goal of this. This act has been introduced. It's currently sponsored on the Democratic side only, but it is getting tractions on both sides of the aisles. But right now they're having a hard time thinking through some of the other things that need to be added. And then the same 340B Act, it's a bipartisan act. I'm going to move on to the next slide because we have a lot more information, but this really would be the act that protects all covered entities equally. And this is, I think, probably what has the best chance to pass because it has bipartisan support. There's a draft legislation. There's been 6 months of meetings really trying to build this out and meet everyone's goals. When we look at this, it restricts the contract pharmacy restriction. There is a fair amount around transparency. So if this act would pass, it would be expected that there would be some type of schedule that would be filed on an annual basis in order to talk about your savings and how you're using those savings. There's a lot of information around program integrity. How is it going to be audited? How are we going to review claims? Duplicate discounts on the Medicaid side. There's some federal PBM provisions in there, as well as a number of other provisions. And it was expected that this was going to be introduced prior to now, but it has been pushed out to at least September. And I think what we know is in an election year, I would expect that Congress is only in session for a limited window in September. So, and then in October, they're going to be out campaigning. So this most likely will be something that gets tackled in early 2025. And then there's also been a number of investigations and hearings, but one we really wanted to call out was an investigation that Senator Cassidy is currently running. And he actually sent data requests to the two big contract pharmacies, CVS and Walgreens, two very large hospitals, both, where I sit here in Ohio, as well as two of the large community health centers. And really what he is trying to do is he's trying to figure out what are your 340B savings, how are you using them, and how is that benefiting the patients? And I think what we realize on the hospital and community health center side, we think we understand that pretty well. On the contract pharmacy side, historically, those have not been pushed forward to the patient. So it'll be interesting to see what comes out of this investigation, and then how is that used for future regulation. And then lastly, as we think through kind of advocacy and really just us trying to be involved with trying to, help educate members of Congress, we spent some time in June visiting with 15 congressional offices, really the offices that make up Ways and Means and the Senate Health, and really focused in on what do you need to know, what are your concerns, and how do we move legislation forward? And some of the things that we heard were, one, they appreciated the partnership and want to see more of that from their local constituents, especially hospitals. They know that there's some good and bad players, but a lot of good players. There's going to have to be compromise. So there's going to have to be compromise both in the covered entity group, because right now there's um, a little bit of feuding within just the covered entities, as well as the covered entities working with wholesalers, manufacturers, and really coming to common ground. And I think that's where some members of Congress are getting frustrated because there is no compromise. But I think what we have seen in the most recent months are a lot of the lobbyist groups and advocacy groups are starting to wrap their mind around there will be future rule changes, and they want to be involved in making that future rule change. And then quick on advocacy, I always like to put that slide in there. I think it's really important for everyone to get involved with that. And I think at first it's kind of nerve-wracking and thinking like, hey, I'm gonna go meet with these congressional offices, but I don't think anything goes further than when you can go meet with your senators and your members of Congress, both at the state and federal level, in order to combat, the manufacturers, as well as really give your voice as far as what does future legislation look like. So always like to point that out. I would highly recommend doing it. It was actually a lot of fun, and I think you'd see a lot of rewards from that. And with that, it looks like we have about 3 minutes.
Yeah.
So I wanted to open it up for questions.
Yeah, Brian and Travis, this is Steve. Thanks for excellent presentation. One question is, won't legislation related to patient definition put 340B access at risk for subsets of patient populations?
Yeah, Travis, you want me to take it, or do you want?
Yeah, go jump for it.
Yeah, and I think, when we think about patient definition legislation, there's a lot of different schools of thought. I think the answer is it depends on kind of how it passes, who passes it. I think the biggest part will be having a clear definition will allow covered entities to really be able to run a compliant program. In many instances, it could very well open up, opportunities. If you think about today where we're sitting and we're losing all of these savings because of contract pharmacy, if we have a clear patient definition and our savings expands, that's that much more savings we can push on to our patients. So I think the answer is it depends. I think a clear patient definition will go a lot further than what we have today, because it will truly lay out for the manufacturers as well as the covered entities who is a patient, and then there won't be all of this debate as far as restrictions and other barriers.
Okay, thank you. Another question, covered entities, when they're looking at strategic opportunities in the 340B program, what is your advice on how they should prioritize that?
I can jump in here, Brian. I think number one is just going to be looking at that entity-owned pharmacy, especially today's environment with the manufacturer restrictions. I think if you don't have one, prioritizing implementing that, I think it's a great win for patients for accessing 340B pricing in a way to really extend some of the financial benefits of the program.
And I think we have time for one more question. And you covered this in your presentation, but I think it's really important. As you look in your crystal ball, and it's tough to predict, Do you think there'll be significant 340B legislation passed the remainder of this year, or is it going to roll into 2025?
Yeah, good question. I honestly think that it'll most likely roll into 2025. I think it would have probably been accomplished if this wasn't such a big election year. I think it'll roll into 2025, but I think two things. One, I get asked all the time, is 340B going away? I truly do not believe that 340B is going away. There is no way that that gap in cost would be able to be made up. But two, I do think that in early 2025, there will be legislation, and I think covered entities can start to prepare for that legislation to really start to dive into what are our savings and how are we using those savings to kind of get a head start on some of those transparency requirements. Because that long list of legislation I put up there, every single one of them includes some parameter around transparency. So I think there will be, and I think you can get ahead of it.
I want to thank you, Travis, and thank you, Brian. Great presentation. 340B is complicated. I think you gave great advice. One of the things you touched on that we're all watching is what's going to be the impact of Chevron, especially as we look at regulatory things coming out of CMS, HHS, et cetera. An administrative note, Chris Wilson will certainly share this with all the people that have registered. And if you registered and missed part of it, a recording of this will be shared tomorrow. And he'll check with Brian and with Travis and Brian and make sure the slides that they're willing to share will be able to share with you as well. But I want to thank both of you for an excellent job, and we appreciate this webinar, and it's now going to be concluded. Thank you.
Thank you so much.